Hello, wonderful attendees. I'm your host, Dalvinder Kaur from lovely Professional University. Get ready to dive into today's topic that is enhancing joint mobility and pain management, the Maitland concept in modern physiotherapy. Before we proceed further, allow me to introduce the expert of the day, Dr. Zaki Anwar, professor in the School of Allied Medical Sciences, Department of Physiotherapy at Lovely Professional University. With 19 years of experience, he specializes in manual therapy and evidence based physiotherapy. Renowned for his expertise in Maitland mobilization, spinal manipulation, and advanced physiotherapy techniques. Before we proceed further in today's session, I would like to request everyone for any questions you can write in the chat box or in the Q&A box, and same will be addressed from my side in the end of this webinar. Now I'm going to hand over this session to our expert, Dr. Zaki Anwar, and it would be an absolute delight to listen from him. Over to you, Dr. Zaki Anwar.
I would really been esteemed as a webinar presenter, as a resource person. I welcome all the participants who had joined this session. It will be really an enthusiasm of working out with you people to share my knowledge about what is the role play in a physiotherapy when a Maitland comes as a significant skill enhancement parameter to give an input to a patients without any usage of the modality. So coming back to the specific content part, why this type of is used on a day-to-day wise of the activity people usually faces, where we should use this manipulation mobilization concept. Coming to a way back in Australia, the GD Maitland has innovated this concept whose outcomes has been a remarkable benefit to the workstation and the several sets of the people who are working in different stress environment. It has got a significant input as a parameter for the treatment came to a picture. So we have initiated several sets of the screening method also while we are evaluating any patients who come as a qualifying participant for the maintenance manipulations. So again, let me give you a small briefing. This is an OER networking site specific link which is being shown on the slides. Everyone, I hope is visible to you, and this specific site will give you an information about what is the need of the specific biomechanical shift mechanism which is being happened with any musculoskeletal deficit where we are using the Maitland concept. And these, before using this concept, we have to really screen those patients on the three basic input parameter. One will be whether they fall in the red flag, the other in the green flag, and other in the yellow flag. Specifically coming to the red flag parameter, they don't qualify for the specific sets of the management of the specific conditions of the musculoskeletal dysfunction. So we are screening when the various participating factor, the contextual factor as per the ICF guideline. Then if that patient qualify for the specific condition for Maitland population, we welcome those patients to undergo those sessions. So what will be an objective part of the specific conditions? We will list out our different thoughts of the manipulation we came into existence worldwide. It is a private specific sets of the passive movements which we are generating on the content of the spine, and the functions get corrected after the certain sets of the sitting. This will be then overall objectives. Followed by that, there are certain grades of mobilization where we are using those grades, where as soon as the patient qualifies as per the condition prevailing with the mild stage, subacute stage, and the chronic stage. So explaining the various treatment concept of the Maitland, they have got different sets of their discipline and the art. As I have mentioned, Maitland had innovated this technique in Australia, and several times of the Hippocrates time also this sets of the setters and bone setters techniques is being innovated way back after the Hippocrates had invented certain sets of the bony dysfunction parameters. So there are several school of thoughts which came into existence 17th and 18th century. The bone setters, I have said, who had been assisted by the physician to classify those patients for the specific condition to be manipulated. In 19th century, osteopath and chiropractor also, one among them are Andrew Estrell in 1874. In 1895 AD, the chiropractic techniques has been came as a different sets of the parameter for the manipulation concept. So coming to the manual sets of the bent of medicinal identity, we are in a state where it comes on as a hands-on technique. So I want to more emphasize what is hands-on, why we are not using any specific modality or our different protocols of the therapeutic inventions we are using in electrotherapy gadgets, and how it is more of a advantageous than any specific gadget which is used for any dysfunction, and why not a Maitland concept. So coming to the complete concept as a flow diagram, I would like to emphasize what are the biostatic stage of a particular person who is presenting with the specific symptoms and signs, and their psychological input along with the specific condition they are prevailing with the particular condition of the patients. So there are certain social contextual factor also, and this all cumulatively together with a specific set of pain symptom which is exaggerated continuously in their spine. So our addressing part as a physiotherapist should be to minimize the pain symptom and reduce the aggravating pain symptom from the prevailing condition by questionnaire, by reassessing the case and formulating our treatment protocol depending upon the different sets of the grades we are using for the spinal mobilization. So there are several sets of the thoughts as in the present context. They are McKenzie technique, Mulligan technique, Maitland muscle energy technique series. These are the innovative skill techniques which we are using in our patient setup depending upon the parts and depending upon the biomechanical content part which is being affected with the particular sets of our qualifying criteria. So there are Butler neurodynamic mobilization also we are using, mobilizing a nerve also, ULTT and LTT measurement where we are dynamically mentioning those specific set of the nerve sensitive pain which is an irritating mechanism with the patients. We resolve those conditions. There are Kelton burn technique which is very much similar to the Maitland concept. There are myofascial technique which we are using on the specific trigger points, and there are positional release technique and sustained contrast strain techniques as well we are using. So coming to the one specific consent among all the school of thoughts, we are using a GD Maitland concept which came into existence in 1950 as I had mentioned, and it came into existence in Australia. So assessment by a specific movement will be one of the specific advantage when we passively move the specific segmental spine to check out whether it is a facet joint anomaly, whether it is a lamina anomaly, whether it is a spinous process anomaly. And if it is a shift mechanism of the vertebral body, that also come into picture. We have to correlate with the X-ray parameters. We have to correlate with the other investigative radiological evidences. So why the specific pain is going to prevail in those conditions, and their ranges which is being much of a painful when a patient moves a particular segmental spine. So whereas the specific set of the physiological movement and necessary movement, we test those glides and segment to check out whether segmental shift part of the total ranges the patient pain got aggravated, and patient is unable to specifically allow you to go further part of the segmental management specific evaluation. So mobilization and manipulation is a one set of the two parameter we go side by side. So core elements among the particular part will be the patient-centered approach. You should be very specific to the patient listening approach. So there is a proverb goes here I would like to mention. Allow the patient to speak spontaneously. He will give you the diagnosis. This many of the physician and the worldwide sets of the medical practitioner, they even practice and some they don't practice at all, which is landing the patient into a wrong diagnosis and landing a patient to lead away with the specific set of the treatment which is not being at all required for the particular ailment. So coming to the specific set of the patient-centered approach, why you should be very much specific to this patient-centered approach, it comes where you have to differentially diagnose what are your specific hindrance in the qualifying mechanism for the particular spinal sets. So identifying and maximizing the movement potential, we should set the parameters, we should advise the patient that this will be your do's and don'ts before I should make you aware about the specific treatment protocol which you have to follow, and you have to follow the advice as well till the sessions will continue to ease out the symptoms from the spinal disease segments. So it is a patient driven model. Listening should be an active part and hearing should be a passive part. As I said, allow the patient, believe with the patient that really he will give you a remarkable information to manipulate on. So at the same time, questioning and counter questioning a patients and their relative to be the actual picture outcome of the prevailing condition. Suppose the set of the parameter I mentioned, that if the patient is suffering from spondylolisthesis and spondylosis, so it might be possible that the vertebral segment should not go for a arthrodesis. This is a segmental fusion of the one vertebra above the other, which should be an specific segmental we should screen while examining the radiological x-rays. And it is an art and science which we can use as an assessment parameter. So what is a mode of thinking? It is a theoretical mode which comes as a theoretical protocol which has an outcome to be manipulated, which is a brief log analogy. So brief log analogy, what does it deal about? So it will deal about the medical diagnosis versus a physiotherapy diagnosis, which has to be get escalated, which been documented, and we should clearly know what specific segmental part we have to evaluate and which we have to leave it. So coming to the specific segmental part, suppose we should use a hip joint pain and the pain in the hip area. It is a very vague topic being answered by the patient. So it is your prime task to screen out what is the basic precursor mechanism the hip joint has got a pain, and that pain factor mechanism you have to evaluate and come to a conclusion and brief the patient. This is the basic specific thing, whether it is an ergonomical thing, whether it is a post-traumatic hip joint pain after the result and RTA, and those things has to be being questioned, and those documentation part will give you a correct picture about what is the exact cause of the hip joint pain. So coming to the specific selection of the treatment related to the patient signs and symptoms, physical therapy diagnosis rather than the diagnostic title should be used as a parameter. So coming to the demands logical reasoning, we should reason out every day, every reassessment day, whenever a patient comes the next day, that whether the patient pain got aggravated or it is limited or the particular pain symptoms has gone down. So reassessment parameter comes here, a very logical parameter to be screened for the patient. So as I said, dysfunction might be related to your spinous process, the vertebral process, the lamina, and the facet joint. So what is the pathobiology mechanism behind it? So these things you have to evaluate and brief the patient accordingly. Sources and causes of the symptoms, as it is been already been documented by the medical set of the physician which is referring the case to you, or rather you had the first set of the practitioner who is evaluating the case. You must escalate all the symptoms and document those symptoms in your sheet on day one, so that the contributing factors from the day zero till the day progresses on for the treatment will be equally documented, and significant outcome measure has to be taken from the patient disease condition. So precautions and contraindication along with this equally goes well with the parallel parameter, followed by prognostic issues after the your set patterns of the mobilization has to be get escalated, and you should tell the patient that this will be your final prognosis after I will make an intervention with the Maitland spinal mobilization. So management part, we works on the different sets of the parameter where there is a torn fiber with extensor. This is one of the exemplary, whether the dysfunction is due to the straightening, whether the set of the elbow pain, which is continuously picking to the patient's mind that it is a very painful grip, or whether it is a very extension part of the origin part with the particular torn fiber if the patient landed up with any sports injury. So this type of the several conclusive reasoning goes to the patient's higher mental function. So one of the specific condition like tennis elbow inflammation, abusive overuse injury, and felt with the go over 2 days, soreness, sickness of the pain, followed by low, whether it is a reddened one, swollen one, and it is often hot at the area where the symptom exists, and it is very tender that patient won't allow you to touch the part. So what is the pathobiological mechanism related with this? We have to find out whether it is a common or extensor origin, radioulnar joint, specific area, or it is because of the radial nerve. This will be your source of origin of the specific pain. So causes and source has to be collaborated, and we have to come to a conclusion whether it is a tight ECRB, shift, stiff wrist is there, and shoulder clinical specific parameter which is yet to be get find it out with the diagnostic symptoms. So painful symmetric test of the fingers you can evaluate. You can do for elbow supination stiffness, and whether it is tingling sets of the parameter which has happened. So ULT can be one of the Butler neurodynamics you can test along with the specific evaluation to check out whether the symptom exists due to any neural in origin, or it is musculoskeletal in origin, or it is due to the any tightness of the band or the fascia. So there are levels of the different segmental thing which contributes to a pain. In a common sense, when we talk to our mother, father who is old enough, or we even talk to our grandparents, they often show that this area he is having a constant onset of pain throughout a day. And in night time, the pain usually subside in the forearm, but many coming to the sets of the treatment protocol, they often ask you as a clinical experts that what will be the effective cause of his pain, which is prickingly, which is being very discomfort to the patient. So here you have to escalate whether it is a facial level, which is in generating the pain, whether it is a muscular level, whether it is a bony level, or whether it is tightness or a trigger point developed due to any injury. So this is how we screen, and we will document it, and we will tell the patient this is the main source of the cause of the symptoms. So generalizing and hypermobility changes to a heavier javelin throwers is one of the specific condition we've seen in day-to-day life. So elbow hyperextension by 20-degree, heavy javelin force going to exert that radial deviation. So it, what is the basic thing is working here as a physics, the torque mechanism of the javelin, which is directly putting a moment of force to the extensor tendon in a hand. This is going to endanger the specific ailing issues of the patients who is a sports athlete, and they may be in danger with the particular sets of the throwing mechanism for the ailing disease. So we have to check out whether there is a hypermobility or a hypomobility. So coming to the specific set of the entrapment of the nerve root, as I've said earlier also, we have to rule out whether it is an entrapment of a nerve, whether it is entrapment generated due to the fascia or a specific trigger point. So precautions and all, we will check out what is favorable to us, what is unfavorable to us. We will escalate those conditions, we'll come to a conclusion that these are the things which we have to mention to the patients, and we have to further escalate the specific provision for the goal and orientation to achieve our objective to elevate the pain from the patients. So what is the basic clinical reasoning out? We come out with a particular clinical reasoning. We will create an idea and an environment for the healing mechanism for the particular set of the parameter which we discuss one of the two of the conditions here. So for the pain reproductions are there in the passive elbow extension and abduction. What is being done passively by you will be one of the input you have to ask for the feedback from the patient, that what is makes you more painful when I will go for this range more than the expected range, from the initial range to mid range to the end range of the movement. So coming to the specific set of the goal initiative, which is being documented by Jones and Revit into 20 2005. They had set a knowledgeable cognition, metacognition role play where the therapist role, where the patient role play in coming to the collection of the data with the subjective interview and the physical examination came into picture. So what is the multiple hypothesis and the perception the patient tells you, which will give you a involved problem concept. Suppose the problem concept came that patient pain symptom originated due to the bony blockage after the post-traumatic fracture. So you have to really work on the primary cause, not working on the secondary causes, which is the secondary in pipeline with a particular set of the condition. So decision making will be, you are the expert to make a diagnostic decision making for the further management to be uh, intervene for the particular condition. So how a patient is going to make a role play. So patients present with the specific hypothesis that this pains is not going, sometimes it originate throughout the day, throughout the months and years together, and it is not being properly understood, and the diagnostic and management was not properly looked out. That is why these patients, most of the patients land up for our Maitland mobilization. And the while proper education, home exercises, treatment strategies development, and the participants learns different follow-ups for the particular ailment to get specific pain symptom improvement after sessions of the treatment being given to the particular patients. So coming to the specific core center, we have taken a quite set of measurement. We come to a conclusion that if the specific set of the parameter what we have defined for the patient is going to identify and maximize the movement potential after the ailing dysfunction get subsides. So don't rush on in the initial set of the particular 2-3 sessions. Let the patient also cope up with the particular treatment session what you are giving to a patients, and it may be possible that your high grade of mobilization of grade 4 might not be acceptable for the particular disease condition which you are using. So here very intelligently we are using those specific set of grades of mobilization while we are mobilizing the specific symptoms for the improvement. Coming the different sets of the core element center approach, we are also putting a scientific art of this cornerstone of the concept, clinical proof gathering, whether it is working or not working. As I've already said, you have to ask every second day or the next session of the treatment whether the earlier treatment made you any issue, or the pain aggravated, or it is more comfortable, or it is improving. So this sets of the parameters of the feedback is very much important. So establishing and test working hypothesis is one of the sets of system we should analyze, and we should develop those first consultation parameter. How to frame a hypothesis, identify an objective, and work on those objectives to make the patient aware that these pain symptoms can be easily manageable with a maintenance mobilization. So here the science and arts exist, where during immediate each treatment sessions, which may exceed to 3 to 4 sessions per week, after break or before the break, give you a final analytical assessment of the prognosis, which is come to an end stage of the evaluation for the patient. Suppose you have given 20 days of the treatment and it is not working. So this is not a good thing which we are working for the patient. We should always ask whether this session is already gone and that much you are focusing in the next couple of weeks, why it is not working on the specific joint dysfunction. So you have to clinically reason out why the things are not working out. So here we are coming to clinical reasoning part. There is other sets of the extent of physical examination and desired effect of the treatment. Based on this, and we can generate an hypothesis, and we can even generate a different sets of the kind of subjective examination. Here the kind of disorders is identified, area of the symptoms, intensity of pain we are evaluating, whether it is an NPRS from 0 to 10 pointer scale where the patient is existing right now. And behavior and signs and symptoms of the pain also being documented, whether it is irritating, whether it is existing throughout a day, whether it is sharp shooting pain is there. Those things questionnaire has to be asked to the patients. This will give you a basic input which grades of mobilization you have to apply for a certain sets of the treatment. So relationship of the pain, stiffness, spasm is collectively working in the specific relationship when you are evaluating a case. So history taking, special questionnaires, as I've told you, rule out the flags, the yellow flag, red flag, and the green flags. So green flags is those flags where these parameters of the Maitland mobilization really works on. So patient profiling, chief complaint assessment, body chart diagram, you have to especially shade out those body charts as the pain factor gets subsided you with the intervention of the particular sets of decisions. So special questions has to be asked to the patients, that these patients should know that what you are treating the particular specific case and what outcome part of the treatment they are going to achieve, and they should be aware that there should be no harm to their any physical input or the sets of the manipulation of the fascia or a muscle or a bone which you are treating. And past history, what with the P1 to P2 we are taking an extent of range of the experienced part of the pain symptom we are managing. So severity of the pain at the limit of the moment can be easily documented. So what are the different clinical picture of the body chart? Get a clear picture of the problem. We draw a movement chart diagram where we emphasize that whether from the P1 level of pain to P2 level of pain, how much is the parameter, is the down index in the exponential reduction in the pain your session has been given to the particular patient. So many times it leads to a specific set of the diagnosis. This is how a moment diagram can be documented from P1 deep dull specific pain symptom reflexes, whether it is a radicular type or it is limiting to a specific set of the joint areas. So this how we always give a patient motivational feedback. From this part you have achieved a lowest segment of the pain from the day 0 to the specific set of the sessions when you are concluding. And this is a posterior component of the segments of the body diagram where we are evaluating which will the specific lower limb pain symptoms. So it might be possible this is generated due to any tendon stiffness, rigidity, or a tender point developed due to the traumatic intervention with a musculoskeletal injury. It might be possible it is due to the prolonged sitting at a workplace, not changing the ergonomics. So it is now today, day to day, the spinal low back ache, non-specific pain also occurs with bad ergonomics. People day to day life they are working at a workstation. So coming to the aggravating and easing factor, there are bending in crossover leg position, getting up from the chair, rolling over in the bed, walking for 5 minutes. These are the specific input for the ergonomical changes should be there to ease out the return to standing, uncrossing my leg, walking for 5 minutes, again comfortably sitting at a position and sitting for 5 minutes. This is going to ease out the workstation anomaly which is directly endangering the patient for the dysfunction issues. So coming to the established symptoms behavior over a 24-hour period, first thing in the morning throughout the day, how the particular symptoms behave, and throughout the night pain or sleeping when the pain aggravates, this should be worked out very sensitively. So work day versus non-work day, how the patient ease out from the pain. Suppose he's not working on Sunday or a weekend. So you have to ask whether the pain is at a bare minimum level or it is of the same level as like the other weekdays. So these things also give you a good picture about the patient's symptoms. So coming to the severity, irritability, and nature and stage, you will find that basis of the planning of the OE, the structures of the examination and depth of examination. I have told we will go layer by layer that whether it is in danger due to the tender spot, whether it is a fascia involvement is there, nerve entrapment is there, which is further going to be worked out for the symptoms improvement. So severity, as I've told, numerical pain scale 0 to 10, we can grade from the minimum level to the maximum level of the severity. Irritability, symptoms and pain, we can calculate with the pain goes maximum immediately with why stand up straight or pain persists for 10 to 15 minutes. After standing up, then it goes off. So this is how you are going to specifically sets the nature of that pain. Type of pain, symptoms of behavior, tissue, injury, sprains, and specific fracture interpretation, which is related to osteoporosis. Other issues like multi-tissue trauma. DEXA scan is the clear specific intervention. We are asking the patient to go for a DEXA scan and vitamin D3 evaluation to find out whether really they have got vitamin D3 issue or the other related issue with the musculoskeletal. So this is how a different degree of the pain symptoms we are evaluating and stage and stability we are establishing. So it is a better one, worse one, or the same one. How the symptoms changes, this patient will give you exact picture. So this last effect of the treatment, immediate effect of the treatment, evening session or the morning session. After the session you had concluded, ask on the second day which intervention of the sessions was more effective for the patient, because we already know when we get up from the morning part, our spinal segment goes one to a specific segment of the minor deviation in the length and height of the particular patient. We got up from the bed in the morning, so these things you have to check, and you have to also inform the patient. This is physiologically happening in all the healthy human individual, that at a morning level the pain perception is at a different state, and in the evening and nights part it is at a different state when it comes to activity of daily living. So palpate, observe, and questionnaire part will be one of the important session part. You have to tell and you have to escalate. So after each technique is used, determine the immediate effect of the technique and determine how the proceeding part of the repeat and modification you have to do for the treatment sessions to come. So determine the effect of the whole treatment sessions of the grades which you have used, and determining the various sets of the clinical parameters which you have implemented for the impairment, and depending upon the physical examination and correcting the parameters on the every sessions which you have done, give a good outcome measure and better prognosis of the condition. So this all will be one of the specific set of the treatment part, and we use different sets of the disorder classification, strengthening with the test movement, and this test movement sometimes comes with a specific orthopedic test assessment we are evaluating for identifying any diagnostic parameter, and a specific spatial muscle test give you a clear picture about different sets of the patients. When they qualify for one specific test, they may not qualify for a other tests. You have to modify the specific test also sometimes to come to a clinical conclusion whether the patient qualify for the specific diagnosis of the treatment protocol which you want to modify or give planning and measurement in the days to come. So hypothesis testing after the objective has been framed by you will be one of the qualifying criteria for the subjects or a participant in the particular parameters of the test. So isometric test, palpation, differentiation test, these are the different sets of the our pressure measurement we often do in day-to-day life to check out if there is any laxity issue with the lower limb knee joint. So this is how P1 to P2, the respective responses we are calculating with the moment diagram. And comparing to those, we come to a specific pain, stiffness, and motor responses. We are examining the patient on the basis of a specific passive mobilization, not its active mobilization. So whether the vigorosity of the technique may going to retake the test, and specific home exercise protocol also continue. So there is one of the specific proverb by G.T. Maitland, a technique is the brainchild of ingenuity. So this is how I'm going to conclude this topic for the today's sessions, and I really appreciate all the individuals and participants who had joined the webinar session and had taken a good input about how to take a good advantage of the smoothly and closely watching the patient symptoms. asking a patient, allowing the patient to speak properly to give you a good diagnosis, and not rush on of the any specific parameter, whether it is a medical intervention, surgical intervention, or physiotherapy intervention, to rush the patient for any specific landing up with the particular set of the treatment, which is not much of beneficial to the patient dysfunction. So it is one of the specific part as an skill enhancement. I do recommend that this techniques is really going to be an input for day-to-days now in specific set of the treatment which are day-to-day part. Every now and then individuals are suffering from in a stressful environment of the world's nowadays. So it is not respect to the Indian continent, it is respect to the Western world also. It is one of the same. When the patient suffers, they should come out with the specific issues of the clinical diagnosis. What is the main involvement of the precursor of the primary cause of pain? We should treat the primary cause, and the secondary cause definitely will work on it, will got elevated. So this is how I'm going to conclude. That's all. Thank you from now. Any question here from the participants in the session?
Thank you so much, our expert, today's expert, Dr. Zaki Anwar. Can you please stop sharing your screen, Dr. Zaki Anwar? As I can see, there are some questions from our participants. Can we take questions, Dr. Zaki Anwar?
Yeah, yeah, sure. Please carry on.
Yes. Gunjan is asking here, what are the key principles of the Maitland concept and how do they contribute to improving joint mobility and pain management?
As I've said in the earlier part of my slide presentation, also, Ms. Kunjan, I would really want to address those issues. What is the basic state of the particular patient that is directly important to us, whether it came in a very early state, in a mild state, whether he came at a subacute state, or he came at a end stage of the chronic. It is directly going to impact which grades of the mobilization we are using in those cases. And they also qualify for a green flag, then only we can go for Maitland mobilization.
Thank you so much, Dr. Zaki Anwar. I hope, dear, you got your answer from our expert, Dr. Zaki Anwar. Can we take the next question?
Yes, yes.
Megha is asking here, in what ways does the patient-centered assessment play a role in the Maitland approach to diagnosing and managing joint-related conditions?
Okay, joint related condition here, I should mention that the specific set of the parameter where we are using this concept, we are also devising there that there should not be any bony blockage. If there is any bony hindrances there in any end range of the mobilization, or it is being documented through any radiological investigation, we should not use Maitland mobilization. It is absolute contraindication.
Thank you so much, dear. I hope you got your answer from our expert. Someone is asking here, how can a physiotherapist integrate the Maitland concept with modern technology and exercise-based therapies to optimize the patient outcomes?
Yeah. In optimizing the patient's outcome, if you add on with the particular sets of your treatment, adding with the modality, it is really one of the beneficial. I do recommend that along with the modality, if you have find that sets of the any our high frequency modality, a medium frequency modality, or any sets of the treatment we are using in day-to-day life with the therapeutic intervention. Along with that, if we use this Maitland concept, will be a better prognosis for the patient. It is an add-on advantage.
Thank you so much. Someone is asking here, what does the Maitland concept differentiate between grades first to fifth mobilizations, and what are the specific applications in treating joint dysfunctions and pain?
As I have said, because in this webinar session, this is a very huge topic which can be handled on a basic parameters of the module. So there are three sets of the module in the Maitland, that we are using certain sets of the parameters of the grades from grade 1 to grade 5, depending upon the patients, from 20% of the below the skin resistance, more than 20 to 50% of the resistance, we are increasing the grades. The resistant and depth part of manipulations get increases, and in the vigorous mobilization part, grade 4 and grade 5, we are not using the specific set of the parameters of the grades, which we are not using for the particular mild symptoms. We are not using high grade mobilization.
Thank you so much, Dr. Zaki Anwar. I hope all the participants got the answers from our expert. If you have any questions regarding admissions, you just write on our set admissions at the rate lpu.co.in, and you can do WhatsApp chat with us. Our WhatsApp number is 98525 69000. I'm repeating this number, 98525 69000. Thank you so much once again, our expert, Dr. Zaki Anwar. In the
Yeah,
end of this webinar, I want to express my deepest gratitude to our experts for sharing their valuable insights and expertise with us. Your presence, enthusiasm, and active participation have made this experience truly special. Hopefully, the attendees found this webinar to be valuable and will be able to utilize the information for better decision making regarding admissions. If anyone wants to access this webinar again, they can visit our website, that is lpu.in, or can be accessed on YouTube also. Stay connected with us for future webinars. Until we meet again, with the permission of my seniors, I would be signing off this webinar. Take care and goodbye. Have a nice day.
thank you very much. Thanks for the participants.